जानकी छोटी टॉक होगी I
हाँ.
think
Yeah.
लोग 15-20
Good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research Education Foundation. To introduce today's speaker and the topic, I hand over to the Secretary of Oref, Dr. Janki Badani.
Thank you, Neeraj sir. Today we have our consultant in our Parasach MRI hospital who is teaching us about osteogenesis imperfecta, which is one of the topic which is very least bothered about in the postgraduate, because it is not well discussed usually. So we have selected this one so he can elaborate on this, and if you have any confusion you can ask in the query, so we'll able to answer those. Thank you so much. So please sir, Jaswinder sir.
Hello, hi, I'm Dr. Jaswinder. So I'll just share my screen. Thanks everyone. So I hope the screen is visible.
Yes sir, quite easy.
So I'll be talking about osteogenesis imperfecta and we'll discuss about the clinical features, introduction, clinical features, how to diagnose it, and what is the management. So introduction, osteogenesis imperfecta is a heritable disorder which is characterized by fragile bones. The bones are very weak in this disease, with blue sclera around the eyes, dentinogenesis imperfecta, hearing loss, and scoliosis. So these are the basic clinical or features or characteristics which one can actually make out that this patient is of osteogenesis imperfecta. In 1979, Sillins classified the disease in basic 4 types based on the genetic and clinical criteria. And the diagnosis of the disease as such is based on clinical, radiographic, biochemical, and genetic examination. The mainstay of this disease, the medical treatment, is bisphosphonate use. And the surgical treatment mainly consists of internal splinting of the long bones. We'll talk about it in more detail. So before we talk about the disease, let us go at the anatomical level and just try to understand at what is happening actually. What is the pathogenesis of this disease? So type 1 collagen is a structure which is actually at risk or at a problem in this disease. And this is the most important structure which is involved in the composition of the bones, the skin, the tendon, the dentin in the teeth, and the sclera. And that is why these are the structures of the body which are involved in this disease: the bone, the skin, tendon, dentin, sclera. So a type 1 collagen actually consists of a triple helix structure. So if we understand in this diagram seen on the right side, a collagen, type 1 collagen consists of 2 alpha 1 chains, which are blue colored chains here, and 1 alpha 2 chain. So the alpha 1 chain is coded by the gene collagen 1A1, COL1A1, and alpha 2 is coded by gene COL1A2. So what happens when this is being produced in rough endoplasmic retinaculum? With the ongoing process, usually there is a gradual folding of these collagen, and finally they are extruded out in the cytoplasm, which is happening normally. And through various processes, it finally forms a fibril, and fibril is a basic composition in a bone or other whatever structures where it goes and gets incorporated. So also when this is happening, the glycine is also present at every third amino acid residue. So what happens in this disease, osteogenesis imperfecta? There is a mutation in these genes which causes the glycine to be substituted by any other amino acid. And the result of all this, what is happening is there is some kind of delayed folding of the collagen chain occurring. So in a normal cell, if this happens, this is actually phagocytosed and taken out by the cell, which is called as like autophagy shown here. But when this process keeps on continuing, like in osteogenesis imperfecta, such fibrils are being incorporated into various structures in the body. And that is how it finally forms deformed bones and whatever other problems are occurring. So that is being shown here. Another important point to highlight here is when the disease is in quantity, when the quantity of this fibril, the pathogenic uh, fibril is when there is large quantity of this is being produced, which is abnormal, this will actually produce a milder kind of disease. Milder, I say milder. But when there is a qualitative defect, like if the folding is very much problematic in there is more of unfolding or more of such kind of qualitative defects being produced, such kind of disease is actually much more severe. So again, 90% of this genetic mutation is actually identifiable, and that is occurring in collagen 1N1 and 1A2 genes. And the disease is actually either autosomal dominant or autosomal recessive. This was the 4 basic types which was classified by Sillens. At present, there are some X-linked diseases, subtypes also being classified recently. So the milder types of the disease are autosomal dominant, which are type 1 and type 4. The severe types are autosomal recessive, which are basically type 2 and type 3. And in the present literature, if we try to search, there are innumerable number of genes which are further added to the family of those pathogenic genes, which are where mutation is occurring. Coming to the diagnosis of this disease, so we'll also include the clinical features for the sake of the DNB students, the PG students here. So the diagnosis is basically based on the family history of the disease associated with the typical clinical and radiographic features. So as such, there is no commercially available diagnostic test due to variety of genetic mutations, as we just discussed. The lab values when done in a typical patient will be in normal range. Other than that, there might be a slight increase in the alkaline phosphatase. There are various methods which are more of theoretical or for academic purpose to diagnose the disease. Like in the skull radiograph, we'll look for Wormian bones. We'll discuss about it. We can do fibroblast culturing from type 1 collagen and do the analysis. And it shows there is a positivity in 80% of type 4 kind of disease. And when an iliac crest biopsy is done in this disease, there is a decrease in the cortical width and the cancellous bone volume is also decreased. So this is one of the important diagnostic criteria. So for a PG, when a child presents or in the exam, this is what all you will look for. The non-orthopedic manifestation of the disease include blue sclera, typically seen here, dysmorphic triangle-shaped faces. I'll show in one or more slides where basically the face will be typically triangular face shaped. There will be hearing loss, and that occurs with 50% of adults with osteogenesis imperfecta. It can be conductive, sensorial, or mixed type. The teeth are abnormal, and the pathology is called as dentinogenesis imperfecta. So there is an alteration in the dentin. They are brown or blue teeth with soft, translucent, and they are very much prone to cavities. The primary teeth, that is in early childhood, they will be much more involved than the secondary teeth. Also, the skull bones will be Wormian skull bones. So they basically, the intrasutural bones. So these are the sutures like sagittal suture, parietal suture. So in between the skull bones, in between these, there will be something like a puzzle-shaped skull bones. Okay, so those are called as Wormian skull bones. The skin is prone for subcutaneous hemorrhages. There can be associated cardiovascular abnormalities like mitral valve prolapse, aortic regurgitation. This child will be much more prone for hypermetabolism, including malignant hyperthermia, hyperhidrosis, tachycardia, tachypnea, and heat intolerance. Coming to the most important aspect of our diagnosis, the orthopedic manifestations. So we know that the bone is very fragile in these patients and they are very much prone for fracture. And that is how that might be the first manifestation in a mild kind of disease. So he might present with a femur fracture, and when looking for there might be some bowing of the femur, there might be osteopenia and so on. Once there is a fracture, the healing process starts quite well, but with time, the remodeling does not occur very well. Also, when there is multiple fractures occurring, that bone will start actually showing some kind of curvature or deformity. And the typical thing when occurs in tibia, they are called as Shaber shin. The child has more prone for ligamentous laxity. The child will be short stature. One of the reasons might be because of the growth is not occurring well, and the vertebra, they show multiple compression fractures. So they are typically called as codfish vertebra. Okay, so this is the typical shape of those vertebrae, and that might also be a reason for short stature in this child. There might be associated scoliosis. In the skull, there might be features of basilar invagination, and when that occurs, the child will present with a upper motor neuron signs, myelopathy. In some patients, there might be a characteristic or a typical olecranon epiphyseal fracture. This might be one of the early presentations. The child also might have a coxa vara. That doesn't occur very commonly, but that can occur in 10% of patients. And again, uncommonly, there can be radial head dislocations also. So in mild cases, a child might present with multiple fractures during their childhood. But in severe cases, there will be fractures at birth, and it can also be fatal. This occurs in actually type 2 of the disease. So most of the children with type 2 disease, they will be succumbing at birth. Fractures decrease with age, and actually there is a tendency for them to stop after puberty. And the multiple fractures are already said, they will lead to bowing of the long bones. When there is associated coxa vara, the child might present with a Trendelenburg gait. And when there is a basilar invagination, there will be signs of myelopathy. So why I am putting stress on this slide and the earlier, because this is what we are going to look for the clinical features when we are examining this child. So there might be deformities, there might be a fracture, which might be painful. Of course, if there is a acute fracture, we will not be allowed to examine that limb. There might be a Trendelenburg gait. There might be signs of myelopathy. There will be, as said, there are deformities and non-orthopedic manifestations like blue sclera, the hearing loss, dentin abnormalities. That is all what we are looking for in the clinical features. So once the clinical features guide us that this is a case of osteogenesis imperfecta, we ask for the X-rays. So in most of the cases, in general, the X-rays will show thin cortices of the bones. There will be a generalized osteopenia. There will be Shaber shins, as already told, deformed tibia. The skull radiograph will characteristically show Wormian bones, and there will be coxa vara. Now we'll talk about the sub classification of the disease, but like in type 1 disease, which is, and type 4 disease, which is milder form of the disease, there might be early presentation with the femur shaft fracture. Okay, and there might be some bowing also. And in type 2 and type 3 disease, which are very severe, the child might present with severe deformities, fractures, and in type 2, it might be fatal during the childhood. Histopathology, more of a theoretical aspect for us. So there will be increased diameter of the Haversian canals, osteocyte lacunae. There will be replicated cemented lines. There's increased number of osteoblasts and osteoclasts because of the ongoing increased bone activity there. There is decreased number of trabeculae. So as such, the bone density is not very good. And finally, there will be a decreased cortical thickness. So this is what your examiner can ask you. What is the classification we follow? The Sillens classification which was given first in 1979. And 90% of the disease is type 1 or type 4. Okay. So the type 1 is autosomal dominant. Type 4 is also autosomal dominant. As said, this is a quantitative disorder. So if you remember, I said in the beginning, quantitative disorder, that is the number of the bad fibrils which are being produced is very high here. And that is why the disease is milder here. Whereas type 2 and type 3, they are qualitative disorders. And that is why this is a very severe form of disease, both of those. The sclera is blue in most except type 3. and type 4. And as said, type 1 is the mildest form of the disease. It presents at the preschool age, which is also called as TADA disease, Osteogenesis Imperfecta TADA. There can be hearing deficit in 50% of the patients, and it is also divided further into type A and type B based on whether there are tooth abnormalities or not. Okay. So in general, if it is difficult to understand, the basic thing you should remember is type 1 and type 4 are milder form of disease. They are autosomal dominant. And type 2 is a lethal form of the disease. The child will actually present, I mean, there will be a death at birth. The type 3 is the most severe survival form of the disease. So that is all you should be remembering. Now, after 1979, there has been so much research ongoing that further subtypes were also given. That is type 4, 5, 6, and 7. Again, if we try to learn in detail, it will be quite confusing. But the classification doesn't end there. The disease, there is a continuum of the classification. And at present, some 19 subtypes have been given. And after that, there is also some X-linked, further 1 or 2 of those are also given. So if you see this is quite confusing. So the important points is collagen 1A1, 1A2 genes are involved, and the basic 4 types, which was given in Sillens in 1979. So this is all. Once you should be examining, looking for your clinical features, examination findings, and finally from your X-rays in the exam. And once you succeed in all those points, you'll be asked about the treatment. So coming to the treatment, the mainstay of the treatment is to prevent the fracture, because these children will actually develop some kind of deformities and all. So that is why early bracing is sometimes advisable, not always, because a very prolonged bracing will actually cause immobilization and osteopenia and further high chances of bone fracture. So early bracing is done to decrease the deformity and to lessen the fracture. Okay. And as already said, bisphosphonate is the mainstay of the treatment. We'll talk about it. So bisphosphonate, the most important drug which is currently being used is pamidronate. So this slide is important. You should be remembering this slide, okay? And bisphosphonate is not only used only in osteogenesis imperfecta, but many other conditions. So for children, whenever we are giving bisphosphonate, this is the dosage and this is the drug we are giving. So pamidronate in a dose of 1 milligram per kg per day for 3 consecutive days in one cycle is given. And this is given for 3 to 4 3 days in the first cycle, and this cycle has to be or can be repeated every 3 to 4 months. Now, if we go to the literature, there are innumerable number of cycles which can be given depending on like 4 to 17 cycles. This is as per the surgeon's choice, or how is the child behaving, how well is the disease being controlled. Okay. Now, how does bisphosphonate act? They inhibit the osteoclast, and they increase the cortical diameter by 88%, and they increase the cancellous bone volume by 46%. So in general, they are increasing the quality of the bone, the density of the bone. They reduce the fracture rates, they decrease the pain, and they improve the ambulation. There's a marked improvement in the pain at 1 to 6 weeks after the initiation of pamidronate. Okay. The ongoing process of the scoliosis is actually not affected by pamidronate. And on chronic use of pamidronate, this is a typical X-ray which one will see. So around knee, there will be some white lines which are called as zebra white lines, or classically they are called as Harris growth arrest lines. Okay, so they'll be seen in the distal femur, or in the metaphyseal region actually, in the proximal tibia, in the fibula, everywhere on the distal tibia. So all metaphyseal regions of the long bones. So these lines actually suggest these are Harris growth arrest line. They suggest that there was one shot of bisphosphonate given at that point of time. It might vary with the rate of what is the rate of the growth of the child, when was the drug given, how much was the interval between the 2 doses of bisphosphonate. Okay. And finally, as per the literature, it is also said that we have to use, actually, whenever we admit a child, we give him a dose of a shot of pamidronate for 3 days, as already discussed. they help in the fracture healing process also. But when a deformity correction with the osteotomy is planned and followed by some kind of internal fixation with the intramedullary rodding, at that point of time, it is advisable not to give pamidronate, because it has been studied that osteotomy, somehow the osteotomy healing is not as well as the fracture healing with the pamidronate. So there should be some 3 months of gap period or some time when osteotomy is being planned, and pamidronate should not be given at that point of time. Zoledronate is one more drug. Most of us might have heard about it, but for children, it is just only in trials and not yet used widely. So coming to the fracture treatment per se, in less than 2 years of age, if a child presents with a fracture, it is actually treated non-operatively and treat as if the child does not have osteogenesis imperfecta. So most of those children will undergo some kind of bracing, immobilization, conservative treatment. In a child greater than 2 years of age, operative treatment is preferable. So it can be done with a telescopy and not not non-telescoping rods. So again, the important point is, whenever we are doing some kind of stabilization in these patients, it is always important to use intramedullary devices, the load sharing devices. A load bearing device like a plate actually is contraindicated because the quality of bone is not good, and there is very high chances of failure of that plate. With there will be loosening of implant and everything will fail. So that is why an intramedullary rods has to be used. Now, depending on surgeon's choice and availability of the implant, we can use rush nails, tense nails, and so on, filling the canal, giving good quality, good amount of stabilization and fixation, immobilization. But whenever there is a possibility or availability of a telescopy rod, it is preferable to use that. Now, what is a telescopy rod? There is a female component to it and there is a male component to it. So basically, the female component will slide out, or it will give way as the child, as the child is growing, the bone is growing. So we need not remove the rod with the time. Otherwise, with the rush nail or non-telescopic rods, we need to, with time, there will be, if we start near the physis, they might after a couple of years reach near the metaphyso-diaphyseal region. There might be chances of cut through, and that is the time the child might present with a fracture and needs a revision. So it is always better to use telescopy rods. So an example, like this child had presented, this I have taken from one of the journals actually. So in mid third, lower third junction fracture of the tibia with the deformity, anterior procurvatum deformity. So this was being treated with a telescopy rod, and at the same time deformity correction was also done. And this is 1 year post-op of that child, and showing that there was around this much distance when it was initially implanted, and after 1 year, that is the amount of telescopy which has occurred, and the deformity is also maintained. There is no increase in any kind of deformity. The correction is maintained. Okay, so one of the important rods your examiner can ask is at present being used is Fessier Duval telescopy rod. Now, many of us might also have heard about Sikh kebab osteotomy. So if we typically see here, that is a telescopy rod, and there are multiple pieces of bone being cut here. So when is this being done? When there is a deformity and which needs correction. So whenever there is a severe deformity, it is always advisable to correct that deformity to reduce the risk of fractures. Okay. So as per literature, it was given by Sofield Miller in the starting. And that is what we do is we cut the bone. Of course, we have to look for the anatomical axis. Where is the lines intersecting? And at those intersections, we do 1, 2, 3, or 4, whatever number of cuts we need to do. And we gradually correct the deformity, align it over the telescopy rod, and we put it in the bones back in the limb. Of course, there is a chances of devascularization, but that is the only way to correct it. So as per the surgeon's choice, one can do use telescopy or non-telescopic devices, whatever is available. A tip some points I'll rush through because maybe this is not very important at the postgraduate level. So whenever a fixation is being done with a rod, it is always better to, center the nail in the center position. So in the AP and in the lateral view, when putting a intramedullary rod, it is very important that the rod is in the center. Otherwise, there is a very high chances of cut through of these rods. Also, while inserting the rods, the bone is so fragile that we might not be able to feel also, and the rod has passed through the opposite cortex while inserting it. So one very important point. Second thing is, whenever those osteotomies are being done, it is always advisable to do with the drill bit and with an osteotome, but not to use the saw because there is a high chances of thermal injury. The bone is as such is already very weak. Bracing period of around 3 to 4 weeks post surgery is to be done. A child might present with a pain, deformity, and fracture after any time, maybe a couple of months, years, anytime. And that might be one of the early indications that the rod has cut through. So it might need some kind of revision. Of course, if there is a coxa vara, so like, for example, not in this case, there is a modification which is described, which is a Wagner modification. So what we do is, while inserting the rod, we also pass two K wires into the neck, and with some kind of like SS wire or fixed system, we stabilize those with the intramedullary rod from the lateral side of the greater trochanter. So that is a Wagner modification. You can go through the paper for details about it. In humerus, when a nail is being put, it is important so that to look for that is there is no subacromial impingement. In olecranon, as I had already shown somewhere, in this picture, it is shown that there is a tension band wiring used with the SS wire, but many a times there is a chances of cut through of this SS wire also. So it is also advisable, as per few papers, to use a thick vicryl or something to, in spite of those stainless steel wires. So finally, for scoliosis, for the exam purpose, and if you are interested in spine, for a curve which is 60 degrees in general, the vital capacity of that lung will decrease by 40% to up to 40%. So whenever there is a curve which is less than 45 degree, so I mean, this is kind of a mild curve of the scoliosis, so it is usually advised to observe such child. And the bracing is not advisable in those children because the ribs are as such very fragile. There is high chances of fractures in those ribs. So that is why bracing is not advisable. In a scoliosis with a curve greater than 45 degrees in mild form and greater than 35 degrees in severe form, posterior spinal fusion is advocated. It is always advisable to use allograft, not autograft, because the quality of the bone is not very good in such children. Anterior spinal fusion is advisable in very young children to prevent crankshaft phenomena. And whenever a scoliosis treatment is done, remember there is a large volume of the blood loss. So that has to be kept in mind. Basal invagulation, as shown in some slides earlier, it might, the child, or basically this presents in after 20 years of age, usually at 30s and 40s. If the child is doing well or at that age group with the osteogenesis imperfecta, he or she might present with myelopathy. And if that is the case, decompression has to be done via transoral approach and posterior fusion. So this slide again is like, you have to know some names. What are the future aspects of the disease? So this diagram is very important, or if you understand, try to understand, it will become very simple. So those are the osteoblasts. That is the osteoclast, and that is a bone structure. And finally, those are the osteocytes, which are the cells are incorporated into the bone matrix. So teriparatide acts at the osteoblast level. Okay. Another newer drug, which is called as sclerostin inhibition and TGF beta inhibition, they all act as the osteoblast level. So they actually increase the bone density. That is how they work. But these drugs at present are again in clinical trial only. So the future aspect might be there is use of these drugs in these children. At present, bisphosphonates are being used, which act by the inhibition of the osteoclasts. Okay, and denosumab, which now we have started using in adults, they act at the level of the rankle, which is the receptor activator of nuclear factor kappa B ligand. Okay, and they inhibit the osteoclastic activity. So when the osteoclastic activity is inhibited, the osteoblastic activity, that there is less of resorption and the bone density increases with that. So somehow this slide you should be knowing, because you might get a theoretical paper also on osteopenia, osteoporosis. So if you remember this, you can write innumerable things there. So as said already, bisphosphonate is being only used, that is an anti-resorptive drug with works with the inhibition of the osteoclast, and that is a mainstay of treatment in osteogenesis imperfecta. All other drugs, denosumab, teriparatide, sclerostin, TGF beta inhibitory antibody, they are all actually in the clinical trial, and some of them are actually not approved for the children yet. So this is the last slide for my talk. So osteogenesis imperfecta is a common congenital disorder. The diagnosis is basically based on the family history associated with the typical clinical and radiographic features. There is no commercially available diagnostic test available because of the variety of genetic mutations. And in treatment, there is a multidisciplinary approach is needed for fracture prevention. The mainstay of the medical treatment is bisphosphonate. The fracture management is the with the stabilization with telescopy or non-telescopy rods, whatever available. And whenever there are deformities, it might need realignment, osteotomies. So there is one case I'll just rush through. This was a case which had presented a 9-year-old male in 2016 to us. I'll just show how bad is this disease, what is happening in this. That is why I just included it here. So he presented with a kind of a subtrochanteric fracture here, and if you see it quite well, so there is some kind of curvature of the femur also. So there is an ongoing disease process, and we stabilize it with a rush nail. Of course, the deformity was not corrected in that setting, and we had stabilized it with the. We wanted to augment it, so we gave with the LCP also. So the child was doing well. This was, and of course, pamidronate was also given. You can see some Harris growth arrest lines in this child, 2 or 3 of them there near the distal femur. This was 2 years post-op, child doing well, no complaints, but the fracture line was still seen. 3 years post-op, the fracture lines more actually visible, and that is the facie of this child, the face. And in 2000, after 4 years, he came with that deformity. He had pain. There was a fracture just below where the plate ended. So prosthetic fracture, you can say, peri-implant fracture with a bending of the implant also. Those were the Harris growth arrest lines, very obvious there. We revised it with a longer plate. We just, we just bypassed the distal fracture with a longer plate. We exchanged the nail with a different nail, of course, center in all the views. And after 1 year, there was good union. There was no bone graft used in this. And this is a typical triangular facie of that osteogenesis imperfecta child. Thank you. Janki?
Yes, please. So we have few questions in the chat box. The first one is asked by Kumar Gautam about the timing of surgery. So what is the usual age the child presents? Because when someone gets a case in the exam, they should know that.
So as already told in one of my slides, in a child less than 2 years of age, manage it conservatively, and a child presenting later has to be dealt. As such, they say that do not treat these children conservatively after 2 years. The reason being that because the bone does not unite well. Again, one of my slides I told, the union process starts well, but there is not good remodeling. So that is the point of time where along with the fracture, we can do deformity correction. So that is why, as such, after 2 years, there is no particular age when a child might present. He or she might present whenever there is a pain, deformity, fracture. And if there is no fracture, and if you see that there is a huge amount of deformity occurring, it should be corrected before it fractures actually. The next question I see is he's asking about ligament laxity management. There is no management as such. We know that. Post-operative care is we need splinting for 3 to 4 weeks. We should not be splinting it for very longer time to prevent the further osteopenia to be occurring. Can we keep battered baby syndrome as a differential diagnosis? Differential battered baby syndrome.
It's according to age, sir.
See, if you go through the battered baby syndrome, it usually again occurs in less than 1 year of age. Of course, it can occur in any year. One has to be vigilant about that. But you can keep that in mind. But for exam purposes, that is not the thing you should be telling that to keep as a differential diagnosis. Of course, there will be more osteochondral dysplasias which has to be kept in mind rather than battered baby syndrome.
Sir, bruising will be there in case of battered baby syndrome.
Yeah. Of course, those signs, that is different thing. Recently, that is a completely different thing. A child with a AMC had presented to my clinic with 5 fractures in one sitting, and the parents were very reluctant telling about the history. He was just some 14 days old child, 14 days, and there were 5 fractures. So I tried to find out. What I got to understand is the parents and whoever the attenders at home, they were trying to correct all the deformities with a lot of efforts, and they caused so many fractures, femur. But again, that is also not battered baby syndrome. But in this case, osteogenesis imperfecta, for the exam purpose, that is not the correct differential diagnosis.
In one slide, you have told about that pamidronate, sir. So that is the drug of bisphosphonate, which you used to give. Yeah, so it is in oral or?
It is in injectable form.
Okay.
So that is why we have to admit the child for the drug, and it has to be given over 3 days and in various cycles at 3 months interval.
And is there any role of vitamin D?
Yes. We have to augment or support always our therapy or treatment with calcium, vitamin D. That is always there. But of course, if we say that not giving pamidronate and only vitamin D and calcium will work, that will not happen. There is osteopenia, so that is a main basic that we have to add those things.
In one slide, sir, you have shown the X-ray of this one, knee X-ray, which is having the lines and all. So in that case, because when during the Viva or X-ray examination, the people gets confused with scurvy and rickets at that time. So what is the simplest way to understand that?
No, these lines are occurring outside the physis. So in the scurvy and all these, there are, if you see, typically those are there will be broadening of the phycing, flaring of the metaphyseal and all. So the typical signs of scurvy are not, or rickets are not the same. Yeah. This is what the Harris group, if you can you see my slide?
Not yet, sir. You please share first. Yes, if you have one rickets slide, then if you can share that one. If you have, then
otherwise I have it just now. Of course, I have to. So just a second. Can you see my slides now?
Yeah.
So those are the Harris growth arrest lines. They are occurring in the metaphyseal region, and there is no other abnormality occurring. The physis is good. The joint is good. The metaphysis outside, there is no flaring and all. Only that the typical, there are just a few lines there, like zebra crossing lines. So that is Harris growth arrest lines. There's nothing to get confused with any other disease in them.
You have mentioned about the rib fracture and that orthotics and all is not so useful. So where we can use the orthotics, like in deformity, scoliosis or anything else?
So see, scoliosis in very young children, one of the treatment is with the braces also, or with the correction of the deformities with the plaster cast and all. In these patients, the ribs are so weak that if there is any kind of pressure which is being put on those ribs, there will be fractures rather than correction of the deformity. So they are not advisable. For the braces, if you ask me, orthotic, yes, post surgical, you can give it for 3 to 4 weeks time, as already said, for splinting for a while till the early union thing is being seen.
Two common question which is used during the viva, sir. Please that this slide if you can.
Repeat your question again. I didn't understand that, Jan.
The common question which is used to ask during the viva, what you have shown is one is sick kebab osteotomy and
Okay.
another one is telescoping rod. So you can please elaborate, because most of people do not see telescoping rod. So how it is, and do we can?
So this is Sikh kebab osteotomy, or the Sofield-Miller procedure. So in the diagrammatic representation is like there is a bowing of the bone. With a single cut or a single osteotomy, we cannot completely correct the deformity. So what we do is there are multiple cuts being done here, like shown here. And once we have achieved the alignment, a straight alignment, a rod is being passed, right? Like a rush nail here. So that is called as Sikh kebab osteotomy or Sofield-Miller procedure.
So it is usually for femur or tibia, like, no, sir?
It can be for any bone, but of course, usually what happens in tibia, the amount of correction is needed is little less. So maybe one or two osteotomy might be enough, but in femur, the number of cuts will be higher. It depends on what is the amount of the deformity you have.
Okay. So inside that one is nail. Over the nail we can.
Yeah. Okay. So next thing you are asking is telescopy rod. So this is a rush nail. Okay, which is not telescopy, and this is a telescopy rod. So what happens if it is a rod within a tube. If you can see, can you see my hand there, Janki?
Yeah.
That is a male rod and that is a female rod. So this is how, like, to start with, that is the kind of the attachment they have. And
If you can, sorry sir, if you can stop slides here, then people can understand it better.
I'll show in that diagram the one of the x-rays also. So in this child who had a fracture of mid-third, lower third tibia, that is a telescopy nail. So the outside or the above, the proximal one is a female rod, and the downside, the distal one, is the male rod. That is some kind of interlocking being given there, if you can say, and that is being fixed in the epiphysis, okay, of the tibia, right? So as the child grows, the female rod has gone up, the male rod is there. So there is some kind of telescopy translation being occurred, and that is how it works in both the views.
Without any intervention, it can go with the growth, like, no, sir. With a growing bone, it can increase its length by itself.
Yeah. So that is a word telescopy meaning of that only.
And so, because you have told bone is quite brittle, so there is any role of Elizarov? Do we can put Elizarov in that? What if?
See, Elizarov is for deformity correction, and the issue is in osteogenesis or any osteopenic bones, it is always advisable to put a intramedullary implant, okay, load sharing implant. The problem is, even with Elizarov, there is high chances of those wires to get free, cut through and all. So of course, if that is why I have not seen till date anyone advising Elizarov, but I don't know. I mean, if one is very much preferable, but overall it is not advised. It is better to use intramedullary rods. Another technique of those Indian style of that is, it was being discussed 2 days back also, about the if we don't have telescopy rods, okay, they are quite costly. There are some Indian version of those now available. So we can use a rod from superior aspect and another rod from a distal aspect. So proximal and distal aspect. So what will happen? Yes, I'll stop sharing. So what will happen is, this is the proximal end of the femur. This is the distal end of the femur. One nail from up, the rush nail or tense nail, whatever you have. Another from down. They'll be overlapping, and with time, as the growth occur, there will be some telescopy. So that is another method being given by in one of the papers in Benjamin's.
Oh, that's great. Another question Kumar Gautam has asked is that the main problem is remodeling, and in remodeling, osteoclast is main cells. Then why osteoclast inhibitors are mainstay of treatment?
Because we want to prevent the resorption. We want to increase the bone density. So at present, we have only that drug which is being working and which is advisable in children. Of course, with time when teriparatide and other such osteoblast activity drugs are being available or recommended after the clinical trials, we might be able to use them also.
And one thing also just I want to ask about the lab findings you have shown, sir. So do there is any value in the lab, any parameter from which we can expect that it is osteogenesis, or is it
No,
normal?
not a single value as such. There might be a borderline increase in the alkaline phosphatase level. Otherwise, there's no lab value to make a diagnosis of osteogenesis.
So it is actually to rule out other
So
syndrome
most
or
important thing is it is based on the clinical features only, and they are so obvious that one cannot miss those things. So that is why it is kind of a spotter in exams.
yeah. So
Okay, so if that is a case in the exam, you'll see the deformity, and one of the differential diagnoses will be osteogenesis. Okay, and other thing is, of course, you'll have the X-rays. You'll see the typical deformities in X-ray. You'll see osteopenia, and if the child has been given bisphosphonate, you will make out those Harris growth arrest lines. So there are enough markers for that. So clinico-radiological is the mainstay of the diagnosis. If availability of genetic examination is there, we can confirm that one.
and the simplest classification to remember for the exam.
Yeah, the Sillens classifications are already discussed, 1 to 4 types. 1 and 4 is the mild type of the disease, and 2 and 3 are the severe form of the disease. There are a lot of more sub-classification being given after that, which is actually, they say, a continuum of disease. So it is the same as the disease in being researched and progress, being studied more and more. There are more classifications being added with time. But again, 90% of the disease falls between type 1 and type 4 only.
So just one last question I want to ask is there when the patient comes, do you advise any dietary modification or any activity modification for the child? If there is no.
I don't think there is any point of dietary modification. There is any clause of that. So that is how. Activity modification, of course, yes, if there is a child with a deformity, okay, and you know that there is a high chances for it to fracture, of course, that child might not be very active. He might be bound in one or the other ways, might be wheelchair bound, or there is a, imminent fracture to occur. The child might be in pain, and that is the time you can give some kind of bracing for that child for the fracture not to occur. Have to advise and counsel the parents to get a surgery done very early, quickly, so that you can prevent a fracture and correct the deformity also in the same way.
Thank you so much, sir. It was very informative for us. Sorry from Orthopedic Research and Education Foundation India that John sir has not able to join today because he is not in the country. And
yeah, that is okay, and that is what we should be continuing, if even if he is present or not. That is a good message for all of us.
Thank you so much, sir. It was very informative. Thank you, sir.
Thank you. Thank you.